All right, I think we can go ahead and get started. Hopefully some more folks are going to keep trickling in. We'll keep an eye on the waiting room and let everybody in case your connection gets interrupted as well. So let me just welcome everybody to the first Hopkins Ophthalmology virtual curriculum event of the year. My name is Nick. I'm a fourth year medical student at Johns Hopkins, joined by my lovely team members here and Dr. Srikumaran tonight, who's going to be our first inaugural speaker of this academic year's season. I do see some familiar names actually from previous years, but I know we also have a lot of new folks who are joining today. So I'm just going to give a very quick overview of what this is, what the virtual curriculum is, and kind of what you can expect from us this year. The virtual curriculum was started at Hopkins a couple of years ago with the goal of increasing exposure among first and second year medical students to ophthalmology and the various subspecialties of ophthalmology, especially as there seems to be kind of a decreasing amount of exposure placed on that field in the preclinical curriculum. So we started this to kind of give you guys a chance to see the field and see the subspecialties in particular sort of through the eyes of faculty members and leaders from around the country who really live this career and their different perspectives. There are a few new things to be aware of this year, even if you've joined us before. Number one, I think many of you saw, we have a website now, which is awesome. That's a place where you can share with people if they want to sign up for our listserv. If you guys have questions for future speakers, that's a great place to submit them. And then you may have seen, we also have a catalog now of all of our previous sessions. Many of those recordings are now available for you to view and check out even after the fact. So if you guys are just joining us for the first time and there's a specific subspecialty you want to check out, please do scroll through the website, take a look, because you might be able to watch a lecture that kind of covers the things that you're looking to hear about. This lecture as well will be edited and posted onto that website. We'll send the link out to that. And then, of course, you can check out the website and see things as they pop up there. We also have a couple new team members this year who I'm going to let introduce themselves. And we have some more stuff that we're going to kind of cover throughout. But we'll go ahead and get started now. I'm going to pass it over to Christina to start off our introductions for the night.
Hello, everyone. I'm Christina. So great to see you all here. I'm a current research year student at Hopkins. And I also want to introduce another member of our team, Nathan, who's an M4 at Hopkins. And I'll pass it along to Kayla, one of our amazing new team members.
Hi, I'm Kayla. I'm a third year here at Hopkins. I'm also loving the management of the new Instagram. So if you guys have not seen it, please check it out. I'm going to put the Instagram handle in the chat. And feel free to, sorry, that was supposed to be an ad sign. I'll put the other one in the real one, but feel free to message me with anything you'd love for us to post. We're probably going to continue to post some educational snippets, some flyers letting you know when we're having events, and nice little trivia here and there. So we'll see how it goes. And then I'll pass it off to Allie.
Hi, everyone. My name's Allison. I am a current third year medical student at Hopkins. I'm very excited to be here with you all. I have a couple announcements before we get started. First of all, if you're comfortable with it, we would like to ask everyone to turn their video on and then also rename themselves to include both their school and their current year of school in their Zoom names. We'd also like to announce that we will be recording tonight's session. These recordings will be available on our website, and we will also send them out to everyone who RSVP'd. And with that, I have the privilege of introducing our speaker for the night, Dr. Divya Srikumaran. Dr. Srikumaran is an associate professor of ophthalmology in the Division of Cornea and External Disease at the Johns Hopkins Wilmer Eye Institute. She received her medical degree from Northwestern University Feinberg School of Medicine, after which she completed her ophthalmology residency and cornea fellowship training at the Wilmer Eye Institute. Her research interest includes the assessment of corneal transplant outcomes and risk factors for receiving keratoplasty through big data sources, including administrative claims data. She's a busy clinician who is actively involved in multi-central clinical trials. She's also a renowned educator and currently serves as the Vice Chair of Education and was previously the Residency Program Director here at Hopkins. Blending her passion for both education and expertise in corneal surgery, Dr. Srikumaran also studies barriers to adoption of advanced keratoplasty procedures in the US and abroad. And with that, Dr. Srikumaran, thank you so much for joining us.
Great. Thank you so much, Allie, for the introduction, and to the whole team, Nick and the rest of the team, for inviting me to speak today. So I'm excited to share with you why, after all this time, I still love ophthalmology. And that is, a little bit of an introduction of what my day-to-day is like, as well as some tips and pearls, because I know that's always on everyone's mind this time of year, especially with applications starting and, just people starting a new year of medical school, trying to think about how they can do the best they can for the coming year. So without further ado, I just want to first share, it's customary for us to share our financial disclosures. I have no financial disclosures relative to this talk, but I do want you to all know that I really do love ophthalmology. So everything I share with you today is going to be biased in that direction. First thing is congratulations. So you're all in medical school. That's already like a big hurdle in your career, in your future career as a doctor, and as far as your adulthood and your profession. And so big congrats to all of you for being here. It's becoming harder and harder and harder to get into medical school. So you have to be real proud of yourself for being in this position. And now the next 4 years, or 2 or 3 or 1, depending on how many years you have left, that is for you to figure out how you want to contribute to patient care and to medicine and to our profession overall, and in what specialty. I, of course, hope that you're going to pick ophthalmology, and that the next 30 to 40 minutes will give you some insights on what that could be for you. But regardless of what you do pick, I think that the future is really bright with how bright all of our medical students are these days. So a little bit about me. You already heard some of this during the introduction, but I'll just add a little personalization to it. So I was born and raised in New Jersey, and I was accepted to one of those accelerated BA/MD programs because I knew at a young age that I wanted to be a doctor. I thought I was going to be a pediatrician. So when I went to medical school, I was convinced that that was going to be my path. And as I spent some time exploring fields within medicine, I realized that while I really liked kids that were healthy and well, I didn't have the emotional stamina to take care of kids that had serious illnesses, terminal illnesses. And I realized actually I don't like death at all. So you can see where, gradually I shifted towards a specialty like ophthalmology, where I'm not really dealing with life and death. And these are things that you'll learn about your personality. But that's the first thing that I would say I realized early in medical school, that I wanted to be a happier part of a patient's medical illnesses, and have something that I could offer patients that really restored their function in some way, in a meaningful way. So after I finished my training, I had the fortune of matching at the Wilmer Institute for my residency. So I did 3 years of residency there. In the past, that's what we had. We had a transitional or internship year that was separate from your ophthalmology 3 years of training. And nowadays, it's actually an integrated 4-year program. So that's a difference from when I had done my training. And then did my fellowship at Wilmer, and actually spent a year in private practice. So when I finished my training, I thought I wanted to be in private practice and be a busy clinician. And I was a busy clinician that first year, but I realized that it didn't satisfy my desire to have interactions with other people as much, with colleagues. So I was seeing lots of patients. I had a great team in terms of the technician staff that was supporting me. But I found myself wanting to share with them the interesting things that I was seeing, and yet they weren't as interested in seeing those things as they were in bringing the next patient back. And mostly they were like, wait, did I not do something on the workup I was supposed to do? It wasn't this exciting, intellectual conversation, which I really missed. And so after I finished that year, that year happened to be a year that my husband was doing a fellowship in Boston. So when we had a natural break point in our careers, we ended up coming back to Hopkins. So I joined the faculty in 2011. Shortly thereafter, I was asked to be the associate residency program director, and then became the residency program director. And then after that, vice chair of education, a role that I've had since that time. Now, in terms of my specialty, I am a cornea and cataract specialist. So my clinical focuses include diseases of the cornea, cataract and anterior segment diseases, as well as refractive surgery. From a research standpoint, as was mentioned, I do clinical research on corneal transplant outcomes. So corneal transplant procedures are also known as keratoplasty procedures. And my research spans from doing chart reviews to clinical trials to big data projects, and even some collaborations with some of our basic scientists. And then on top of that, I have my other sort of arm to my interest, which is in medical education. So we have explored areas on how to improve medical education as well. So a brief overview of corneal anatomy, since this is something that I know many of the students on the call are new to ophthalmology altogether. So the cornea is the clear sort of glass cover of the eye. And what you'll see here is that when you look at this cornea in higher magnification, that there's 5 layers. There's the endothelium, Descemet's membrane, the stroma, Bowman's layer, and then the epithelium. The endothelium is closest to the aqueous humor, which is in the front chamber of the eye, and the endothelium is responsible for pumping fluid out of the cornea and keeping your cornea from becoming swollen. The epithelium, if you get a scratch in it, you can develop significant pain from like an abrasion, for example. So just a quick orientation to the cornea. Now, as I mentioned, corneal transplants are one of the procedures that corneal surgeons perform that's unique to our specialty compared to, for example, a comprehensive ophthalmologist. And it is also one of my areas of focus for research. So why do we do transplants? Well, we do them to restore vision. We do it to alleviate pain, eliminate infection, or to restore the integrity of the eye. So this is one of my patients who presented with a perforation. You can see right here, that's actually a hole in the eye that was leaking fluid from the eye. In the setting of an infection, there's a lot of inflammation in the side. So we had to do a keratoplasty procedure, and you can see here a full thickness transplant. So this is a post-op picture a few months later. And again, this was done to restore the vision, to alleviate some of the pain, restore the integrity of the eye, and treat the infection. So the first example I just shared was a penetrating keratoplasty. So it's a full thickness graft. What you see here in red is the donor tissue, which was used to replace the host tissue. You can also do what we call a DALK, which is a deep anterior lamellar keratoplasty, where you replace just the anterior layers of the cornea, the epithelium, the stroma, and you leave behind Bowman's membrane, and you leave behind the Descemet's membrane and the endothelium that the host has. You can do a DSEC, where you're actually replacing the inner lining. So you're taking a donor lenticule that has endothelium, Descemet's membrane, and a little bit of stroma, and attaching it to the back of the cornea from the host. Or you can do DMEC, which is an anatomically correct replacement, where you remove the host Descemet's membrane and endothelium and replace it with a donor Descemet's membrane and endothelium. And then you can do also a keratoprosthesis, which is actually an artificial cornea. So this is a plastic and a metallic foreign cornea. It's put into a donor tissue carrier, but it is an artificial cornea. So keratoplasty procedures are the most common tissue transplant in the United States amongst all organs. And in the United States, we are so fortunate to have a very robust eye banking community that there is no wait list for corneal transplants. I can order tissue from the eye bank in anticipation in any of my patient's surgeries, and they do an amazing job of finding tissue that meets my specifications, and not only finding the tissue, but also processing it in a way that would support me in my surgery for my patients. So this is not the case for corneal surgeons in other countries. In other countries, there's a shortage of tissues. The eye banks don't have the capability of processing the tissue. There can be situations where surgeons actually have to go harvest their own tissue from their local hospital, or that there's a wait list. So this is a privilege that we have in the United States. And this is some data from the Eye Bank Association of America, which shows the number of keratoplasty procedures that are done annually in the United States. So if you look at sort of the last 15 years in the red line, you can see the endothelial keratoplasty procedures, which are in combination both DMEC and DSEC surgeries, and that's been increasing. So around 2012 is when they actually surpassed the number of penetrating keratoplasty procedures, which is here in the blue line. So this is an evolution in the way that we do keratoplasty procedures. And overall, because we are able to do the endothelial keratoplasty procedures, which are a little bit less invasive, safer, better outcomes, we've expanded the indications for doing them. And so we've had an overall about 20% increase in the number of transplant procedures that are done in the United States over the last decade as well. So what are some of the reasons that we do transplants? Well, one of them is Fuchs. That's the most common indication for transplants in the United States. Ernst Fuchs was an Austrian ophthalmologist, and he described this condition because at first as dystrophia epithelialis corneae. So what he noticed is that in end stage Fuchs, patients would present with these painful bullae in the epithelium, so basically painful blisters on their cornea. And this condition actually, though, is a hereditary condition. That the first early stages, what you see are these little guttae on the endothelium. And there is a female predilection. And with these guttae initially, you will see these, and patients have decreased endothelial cell counts and endothelial function. They develop corneal edema. And then as the cornea swells, the patient's vision gets blurry. And then in advanced stages, the patient can develop the bullae. Again, this is the most common reason for transplants in the United States. And so I wanted to share with you a quick video of one of my cases. This is frequently done in combination with cataract surgery. So many times patients who have visually significant Fuchs, because they're in their middle ages, they also have cataract. So we take out the cataract, we put in a new lens implant for the in place of the cataract. And then here we're doing a DMEC surgery. One step is to create a little iridotomy in the cornea so that the patient doesn't develop pupillary block, which is where the eye pressure can go real high because we're putting gas inside the eye. Instead of putting stitches, we're using actually an air bubble or a gas bubble to hold that transplant in place. And here we're removing the host Descemet's membrane. So that's that clear membrane that's coming out, clearing up all of the viscoelastic that was put in the eye to help maintain the chamber. And then this is where we're drawing the tissue into the eye. And you'll see that we're using the infusion and the forceps to unfold this graft and then put an air bubble, which is actually a gas bubble, in the eye. The suture that we place is just to close the main incision. Unlike a full thickness transplant where you're putting multiple stitches in the cornea to hold the tissue in place, there's actually no stitches here, and patients do really well. So this is the patient's post-op picture. You can't even tell that they had a transplant. One thing that if you notice here very subtly, there is an S. And that's the S stamp that the eye bank puts on the tissue as an orientation marker so that you know when you put your graft in that it's in the correct orientation. So if that S wasn't there, it's really hard to tell that the patient even had a transplant. So what are some other reasons that that I do transplants under some other common corneal problems? Well, one is corneal bullous keratopathy. So that's just a term that's for corneal edema. Again, bullae meaning the epithelial blisters. So just different degrees of bullous keratopathy. And again, this can cause blurry vision as well as pain for the patient. So this is an example of a post-op patient in which the eye was more complex. So we do DMEC for that normal eye with Fuchs, and this was a patient that had a sutured lens, a lot of iris trauma, and had a what we call a prior vitrectomy, which means that the jelly in the back of the eye had been removed. And in those eyes, it's much more tricky to get a DMEC surgery to be successful. And so in this case, I had to remove some of the scar tissue from the iris, put a stitch in the iris. You could see that it's kind of closed here, and placed a DSEC surgery. And pre-op, the patient was 2400 and his vision improved to 20/30 post-op. So you can make a big difference with the surgeries. And sometimes we have to do multiple surgeries at the same time to help rehabilitate the patient's eye. So going back again, we talked a little bit about DMEC and DSEC. I want to go back again to PKP and DOC. So here's a picture of patients. This is a full thickness transplant, and this is a DOC. You can barely tell the difference when you look at it just with the naked eye, but under the slit lamp, you can appreciate that the patient's host endothelium and Descemet's membrane is intact. The reasons that we tend to do these are different because it would be anterior stromal pathology. Here's an example of one of my patients, and what you can see here is that the patient had a really large scar. The patient had a corneal ulcer from contact lens use and an infection that required placing a flap of conjunctival tissue because the cornea was melting and thinning. And this is just the recovery surgery basically to help rehabilitate the vision once the infection was treated. And we performed a DOLC using what we call groove and peel technique. And so basically I removed the conjunctival flap, and now I'm removing some of this anterior stromal corneal tissue, as much of it as I can, all of the scarred tissue, sort of going in circumferential grooves around the cornea. And, you have to take this and do this dissection very carefully because you don't want to perforate the Descemet's membrane underneath it. This video is fairly abbreviated, but this, what I would say, is like the long surgery that I do in ophthalmology, can take 3 hours even sometimes because of the time that it takes to carefully dissect the cornea. And then what we're doing is stitching the cornea back on after removing the donor's Descemet's membrane. So this is how the patient was doing post-op. So pre-op, you saw the picture that was in the video. You can see on an OCT how scarred the cornea is, how thin and irregular the cornea is. And now we've restored a much more normal contour here post-op, and the vision has improved dramatically as well. So one of the questions that was posed in the prior Q&A was sort of, how do you balance clinic and surgery and sort of your schedule overall? Ophthalmologists will manage their schedules in all different ways. A typical schedule for me varies between having typically a day a week for academic research time, and then having 1 to 2 days per week for surgery and 2 to 3 days per week for clinic. So basically, for me, typically Monday is my academic day where I'm doing other administrative research, et cetera. And then Tuesday to Friday are clinical days. And it varies a little bit depending on my OR time. So why do I still love ophthalmology? Well, possibly you gathered from those videos I shared that, restoring sight and having an impact on our patients' lives is incredibly meaningful to me. And Nick has been with me in clinic and sort of seen my one-day post-ops. That's my favorite day of the week, is just after cataract surgery, being able to hear immediately from patients the impact that something I was able to do for them has on them. You get a lot of hugs, you get a lot of comments on things that they were seeing that they couldn't see before, and sort of just sometimes tears of joy. And so that never gets old. I've been doing this for over a decade, and it is something that, when I started ophthalmology, I should say that I thought I wanted to do retina because when I was a medical student, I loved looking at pictures and pathology of the retina. It was fascinating to me that you could see stages of diabetic retinopathy and macular degeneration. That's what I had done some research in. And then I did some cataract surgery in residency, and I just fell in love. And so like I said, it's still my favorite day. It's not that I don't love all the other things I get to do. I love mentoring future generations, whether it's students, residents, fellows, and being involved in the discovery process and being able to research questions that have direct clinical relationship to patients that I'm seeing and taking care of. So all of those things have enriched my career. My path that I shared with you hopefully has shown you one thing, is that even though I've been at Hopkins for all these years, my job and what I do has changed a lot as well. And that's been one real big plus for me of being in academic medicine too. Many people, when they want to change their careers, they have to leave their organization, they have to leave their company, or they have to physically leave geographically. But I've been able to change a lot of what I've been doing and sort of pivot and refocus and do new things that are exciting to me, all within one overarching institute and organization. So that's been a real privilege for me as well. So that's a little bit about me. I wanted to switch gears and talk about a hot topic, as I mentioned earlier, applying for residency, because I know that this is something that some of you are going through or thinking about in the future. And maybe some of you have some anxiety around how competitive you perceive ophthalmology to be. So ophthalmology is an early match through the SF match. It's a 4-year residency, as I mentioned, and it's a PGY1 integrated or joint program with 3 months of ophthalmology in your first year of training. 9 months are distributed amongst medicine and surgery or other rotations based on individual programs. Those can be quite variable. In 2023, there was a nearly 70% match rate. That match rate is higher for U.S. Medical school graduates than it is, for example, for international medical graduates. And the SF Match website has a lot of great resources. It has some of the stats that I mentioned. So for anyone who is still early on in their medical school training, I think it's a great idea to just familiarize yourself with this website, to just see what the timelines look like, see what the prior stats are, not to make you nervous, but just so that you have an idea of what's to come down the road. So as you can see, the number of positions in ophthalmology have been increasing a little bit over the last several years, but for the most part, it's about 500 spots, but typically there's about 800 registrants. So not everyone who applies in ophthalmology will match, but that is still a high 60s to 70% match rate. So many applicants will match, and I don't want these numbers to steer people away from trying at all. Now, I will admit to you that the Wilmer Ophthalmology Residency Program is one residency program, and our mission is to train future academic leaders in ophthalmology. This is our mission statement. Graduates will demonstrate the ability to provide the highest quality of patient-centered care, educate future physicians in training, and conduct innovative research that will improve the lives of patients. So this is our mission. This is not the mission of every single residency program that's out there. And so what I'm about to share in the next couple of slides is my perspective, knowing what we look for at our program. And I want you to take that with a grain of salt, knowing that other programs may have other directives and missions and goals and have different things they look for in trainees. So I don't want anything I say today to stress anyone out. And there are lots of programs, over 120. They all have their own sort of mission, their own features, their own culture. And one thing I will tell you is that with all of them, when you graduate, you have the opportunity to become a board certified ophthalmologist. And that means that you will be able to practice as an ophthalmologist. And so once you get to that point, there's so many things that you can still consider afterwards. So I don't want anyone to feel like the possibilities are narrowed or they're limitless, really. So application components, things that we look at. First of all, preclinical grades. Really, in the past, they could only hurt you if they were really bad. Nowadays, more and more medical schools, the preclinical grades are pass-fail, so they're really not that meaningful in terms of your application process. You want to learn this material so that you can do well, so that you have a good concept of the sort of the scientific basis of disease and medicine overall. But again, most places are now pass-fail. Clinical grades, again, also becoming pass-fail at many institutions, but if you do still have grades, then the ones that you really want to try to do really well on are like your core medicine and surgery clerkships, as well as for ophthalmology, for example, your ophthalmology clerkships. If you're doing another specialty that's similarly competitive, you're going to want to do well in those related clerkships as well. Now, research exposure and productivity, I would say for our program is highly desired. In some places, this may not matter as much. But what I find is that in nearly all of the applications that are coming to our programs, we get over 600 students are doing research, and it varies. It can be from full-fledged manuscripts that have been accepted to manuscripts that have been submitted. It can be posters and presentations at national meetings, or it could be works in progress. I kind of listed them in the order in terms of how impressive any one feature is. Obviously, if you have a paper that's fully completed and accepted in a journal, that shows us that you kind of stuck to it and took a project from the beginning to end and had a complete product to show at the end of that process. So that's more impressive than something that you're working on but haven't made much progress with. It's always hard to know what a research project in progress is. I would also say that when you are involved in a research project, if you're able to sort of take the lead on a project rather than maybe having a more ancillary role, that's always more impressive as well. From a USMLE standpoint, historically ophthalmology was competitive, where USMLE scores on step 1, you'd want to have something, roughly above 240 to be safe, so to speak. Now that step 1 is pass-fail, there's a little bit more emphasis on step 2. And so trying to aim for above that score can be helpful. Letters, really, these are recommendation letters where you're getting to choose who's writing your letter. So they have to be strong, and you have to be thinking about developing relationships with people so that they would be able to write your letters from early on. So think about ophthalmology faculty with whom you can try to build a longitudinal relationship so that they could get to know you and be able to write in a strong letter on your behalf. Think about clerkships in other areas, whether it's medicine, surgery, or other arenas. At certain medical schools, you have longitudinal experiences with other faculty who could be potential letter writers for you. It could be a research mentor, even if it wasn't someone who did ophthalmology research with you or worked with you clinically. But think about people who know you well and who would be able to write positively and strongly about this. And think about whether they can comment on the distance traveled. So our focus now is to really do a holistic review for applicants and to look at beyond things like step scores, for example, or just, the number of papers, et cetera. And so some of those you're going to be able to share with us in different components of the application, where you're talking about the other activities, awards you receive, like AOA, Gold Humanism, degrees that you've had. You may be able to comment on your leadership roles. With all of these, it's much more helpful if you've done something substantial with it. So, being a leader of a group, starting a new group, having a real integral role in something where, again, one of your letter writers might be able to comment on what you've done is helpful, or that you can discuss both during your interview or elaborate on your application, so that we understand the depth of your commitment and the depth of your involvement. Again, your personal statement nowadays on the application, you get to choose 2 or 3 questions that you can answer, rather than just having a sort of a free-for-all. And within that, really think about sharing with us why you want to do ophthalmology. Help us get to know you. And again, if there's things that you can comment on, the distance traveled, what makes you unique, what makes you tick, so to speak, I would try to comment on that as well. The interview impression, we know you're nervous. It's 10 to 15 minutes. We're really trying to get a sense of if you're the person you appear to be on paper. One thing I would encourage everyone when you're going through your interviews is to just try to be yourself and to try to convey who you are the best you can. I mean, you have a few minutes to share your personality, to share what has motivated you to go into ophthalmology. And I would encourage you to share things that are personal stories about yourself and your experiences, because that's what makes you you, and that's what helps us remember you. So, just again, these are your experiences that you're sharing with us, so that we can have a glimpse into your background. So a few pearls for success. A lot of this I share with the residents every year when I was program director, sort of setting them up for residency, but a lot of this is very relevant for medical students as well. So getting into residency, your medical school career, 4 years, it's not a marathon. It's not a short race, it's a marathon. So you really have to pace yourself. And I do encourage people to get involved early. So what do I mean by that? So get involved with research projects early. It takes time to collect data, to analyze the data, to write it up, to try to have an opportunity to present it, to have a chance to try to publish it. You can't start that 4th year of medical school and expect to make reasonable progress with it. So these are the types of things that you really want to start your 1st or 2nd year of medical school, knowing that it takes time. And so, again, it's not something that you can sprint and finish. Ideally, try to identify projects that you could take the lead on. Attend national meetings to present your work as much as possible. Ophthalmology is such a live community. At meetings, you have a chance to meet other students. You have a chance to sort of see everything that's going on beyond what your project was. It's an amazing learning opportunity and an amazing way to network with other people. And so make that a goal for yourself. Try to identify some meetings that are smaller, maybe, that would be amenable to medical students presenting. Women in Ophthalmology is one organization that has summer meetings every year, and they do have prizes and awards and are supportive of trainees. ARVO has training grants for students to present. The NMA has the RAB Venable competition for students to present. The Cornea and Eye Banking, Cornea Society has the EBA forum, in which medical students and fellows and residents are able to present. So try to target a meeting that's related to the work that you've done and try to present your work. Social service groups or health clinics, anything that is happening through your medical school and in your community, get involved early. This is a great way to explore what ophthalmology is. It's a great way to see if you like it. It's a great way for you to try to give back to your community. And also to do something that makes you feel like a doctor. Your first couple of preclinical years, you came to med school all excited to take care of patients, and then you're spending your time doing a lot of more basic science work and book work, and there's not a lot of human and patient interaction built into your curriculums many times. And so this is a great way to feel like a doctor and do something for patients. Look for leadership opportunities both within your school and community, and again, through organizations that may be present nationally, like your state society or the academy. When you're not sure what you want to do, trying to shadow in clinic and or surgery early can be very helpful to see if it's something that you actually do like. As was mentioned at the beginning, that ophthalmology has kind of been marginalized a little bit. And so if you're not proactive about seeking it out and having some experiences, you could go through all of medical school having never been in an ophthalmology OR or a clinic. So you do have to seek it out more than you would for other specialties. Be prepared. So it's just not enough to show up. If you want to excel, you have to come prepared. Well, how do you do that? There's so many resources online. This is the American Academy of Ophthalmology's resources for medical students. It goes over topics that you should know. It goes over how to do an exam. There's numerous YouTube videos that teach you basic exam skills. So if you show up in a clinic that, we tend to have in ophthalmology, very fast turnover. So, your attending might be seeing 30, 40, 50, 60 patients a day, depending on their practice. So there isn't a lot of time for you to examine patients. It's not like the inpatient wards where the patient has nowhere to go. Patients need to get in and out and have somewhere else to be. So you have to try to be real efficient when you're in a patient exam encounter. And so the more you're able to do, the more you're going to get to see and learn. Again, there's numerous YouTube videos, and I would highly recommend that you practice these skills with a buddy. So whether it's other students in your group that are in your grade or medical school class or other classes, or your roommate, whomever, find a buddy and practice these skills. Again, when you practice with a patient, they might be a little uncomfortable. They may not be comfortable to tell you if something you're doing is not quite right. And whereas a partner that is another student might be able to give you some feedback too. And then reach out to seniors that are applying in the same specialty. They are a great resource and also can probably give you a lot of tips on how to do some of these things. Work as a team. So this is where, it is a competitive specialty. I think it can create some sense of competition among students from the same class that are applying in the same specialty, but it's a small community when you finish as well. And so, really trying to build relationships and help each other is going to take you a long way. Build a network both with students within and outside your institution. And that's why I do think that this virtual group that you all have created and have fostered is such an amazing format for you to build those connections with each other and help each other and continue to do these things with each other. Learn as much as you can and keep an open mind. So you may have already, you might be an M1 who has decided they want to do ophthalmology, but don't specialize too early. As much as I love that, I want you to keep an open mind. As I shared with you, I started off thinking I was going to be a pediatrician, changed my mind, ended up in the best specialty for me. Thought I was going to do retina, changed my mind, ended up in the best subspecialty for me. So keep an open mind. Learn also about as much as you can about other fields, as this may be your last chance to learn that. Remember, you're going to have an MD after your name. Everyone, whether it's your neighbors, your family, they're going to expect you to have some basic knowledge of medicine. You have to have sort of cocktail party knowledge. When people want to know about the rash on their hand, even though you're an ophthalmologist or whatever it is, they're going to expect you to know something. So this is your chance in medical school to get that cocktail party knowledge to help your family and friends with whatever they have, whatever they need you for. And finally, patients first. So ophthalmic surgery patients, one sort of little pearl I want to point out is that patients are awake during surgery. So you have to be very mindful when you're in the operating room and observing that you're aware of the fact that this is a patient who is likely anxious about the fact that they're having surgery. And when they're hearing things that are being said, it can add to their anxiety. So you always want to think about what you're saying, how you're asking questions in a way that doesn't make them feel more nervous. And, I would also like to say that as a student at this stage of your career, you may feel that it's hard for you to help the patient, but I just want you to always think about how you could be an advocate for their well-being and sort of put yourself in their shoes and what you think they might be going through. And if you do that, you'll always find a way to help them. So circling back to what I started with at the beginning, coming full circle, you've all jumped over a big hurdle. And I know in some ways getting into medical school and being where you're at feels a little bit anticlimactic, because now instead of that horse that jumped over that hurdle, you may be feeling a little burdened, overburdened, like this donkey in this picture. But I want to share with you what my husband always said to me whenever I would feel a little stressed and overwhelmed. And I mean this to be funny, but he would just tell me all this time, he's like, you can do this. Dumber people than you have done this before. And I know how hard, I haven't read your application, so I don't know all of you individually, but I genuinely know how hard it is to get into medical school. So if you have gotten to this point, I know you have what it takes. If you want to do ophthalmology, you can do it. So with that, I'll say thank you and good luck, and I'm happy to answer questions.
Thank you so much for that excellent presentation, Dr. Srikumaran. A lot of ground covered and a lot of great pearls in there. So we are going to switch gears into the Q&A portion of this session. For those who are unfamiliar, the way we usually do this is with the raise hand function of Zoom, just because we have so many folks in the call. If you click that raise hand button, I think it's under the reactions or over on the participant side, you'll pop up on our screen here. And then kind of in the order that questions come in, I'll call on you and we can kind of go from there. We also had some submitted questions from earlier, so we might mix in a couple of those at the end if we have some time. For those who have been through this before, one thing I can promise you is that I'm probably going to pronounce your name wrong, so I apologize for that in advance, but we'll go ahead and get started. Is it Nat? Do you want to go ahead and ask your question?
Yeah, thank you so much. I think you alluded to the fact that in ophthalmology, you enjoy it because there are problems that can be solved. But can you maybe talk a little bit about the challenges in cornea or ophthalmology in general that have yet to be solved, that we can, like the next generation of ophthalmologists can try to tackle these problems, and what innovations in cornea and ophthalmology we can look forward to maybe 10, 20 years down the road? Yeah,
so there are many. Unfortunately, there are still lots of things that we can't solve. Patients with severe, in cornea, patients with very severe ocular surface disease, for example, that have bad limbal stem cell deficiencies, we still can't do a traditional transplant in those patients and have that transplant restore their vision. The current keratoprosthesis techniques that are available are fraught with complications. So while it can give patients vision, long-term, the outcomes are not as good as we would like. Glaucoma tends to be a problem that makes those patients go blind. For example, in other specialties, there are similar challenges. For glaucoma, there are some patients that have very severe and advanced glaucoma, and we don't have a way yet to regenerate the optic nerve. And so sort of reversing blindness from glaucoma or even retinal degenerations, for example, is an uncharted area that lots of people are working on, but we don't have anything in the pipelines. But boy, would you make a lot of patients much better off. Could you help a lot of patients in so many ways if you could do that. And so that's just the tip of the iceberg that I mentioned, but there's so many areas that have a lot of room for improvement. So don't worry, there's plenty for you to do.
Thank you.
Tal, do you want to ask your question?
Oh yeah, thank you. So thank you so much for the talk. It was really helpful. I'm applying right now, so it's especially helpful. And I just have a quick question. There's a lot of differences this year in the application, and one of those differences is a lot of supplemental essays about why you picked the school and some other questions that they ask. So my question is there a way to make yourself stand out when answering those questions? And if they don't have a supplemental essay, is there a way to signal programs, even though the application doesn't have signals?
So we don't have signaling. It's something that is being discussed on a broader level. And so it isn't right now. I think that one thing that's happened over time is that applicants are applying to like all 100 programs. And so then programs are getting a large number of applications from people who aren't even that interested in them. And so some of the supplementals is just to see, is there some genuine interest in our program, or are you just applying to every program out there because you're worried about your chances in matching? And so there's been discussions in the past about limiting the number of programs that an applicant could apply to try to help curtail this. Again, to try to help people find a better match for themselves rather than, again, just blindly applying to all the programs. I don't think there's a good solution yet. I can tell you that people are very much actively thinking about how to make it fair, how not to disadvantage applicants in the process in any way whatsoever. But also, if a program can only interview, let's say 45 to 60 or sometimes less, you do want to pick people and invite people for your interview that want to be there, because you don't want the same people getting the interviews everywhere. You really want to try to sort of make it a little bit more equitable. So no way to signal through the process, but one thing that some people will do, and I don't know how effective it is, people will write letters of interest to program directors. I can tell you at this time of year, they're getting bombarded with emails, and I don't know. I never personally cared for getting those letters, so I don't know how much other people care about it either, because like I said, we're getting bombarded with emails. I think hearing just that you're interested is I appreciate that, but it's not going to influence the outcome, I guess is what I'm trying to say.
Thank you.
Let's go to Hassam and then Brian after that.
Hi, thank you so much for a great talk. I just had a quick question regarding letters of recommendation. So I know you mentioned the types of people we should ask letters from. I've heard varying answers from different attendings on the breakdown between how many letters we should get from an ophthalmologist versus from someone in internal medicine. Is it okay to have 3 letters from ophthalmologists? What are your thoughts on letters of recommendation specifically?
I think the key is people who know you really well, or the best, and who could be your strongest advocate. So getting an ophthalmologist to write your letter who was like, oh, the person came to my clinic twice over the past 4 years, that's not helpful. But someone who worked with you over a period of a year or two, who really knows you and can speak to your strengths on numerous levels, that even that person from internal medicine, way more valuable. So I think about the depth of your relationship and what you think they saw you do, so that they could comment on that more so than just their subspecialty. Now, if you have an ophthalmologist who knows all those things about you because you built those relationships, then I will say that it is a small community. And so we tend to know each other, and, hearing something from someone I know, over time, I know these people. I can't say that I don't want to say the word that you trust them more, but it just has some influence on you, and sort of knowing that these are like-minded people looking for similar characteristics for their own trainees. Their vote of confidence is meaningful.
All right. Thanks so much.
Mm-hmm.
Hi, everyone. And yeah, thank you so much for your inspirational words. It really meant a lot. And thanks to everyone who organized this. Personally, at my school, I think we had maybe 3 or 4 lectures on ophthalmology. And I was like, that's it? Really? This is what I want to do. But I had a specific question for you regarding corneal cross-linking.
Mm-hmm.
I had the wonderful opportunity of working along a corneal specialist for a couple years. And we did it a lot on usually younger patients, and just reviewing their imaging and all of that, it was kind of pretty variable results that we'd get from that procedure. So I was wondering about your experience with it and your thoughts on it.
Yeah, so cross-linking, just for everyone on the group, it's a procedure that's done for corneal ectasia, specifically keratoconus or post-LASIK ectasia. So patients are developing progressive irregular astigmatism, steepening of the cornea, and thinning of the cornea. In general, the indication for doing cross-linking is that there is some sign of progression. So patients tend to be younger because keratoconus, for example, tends to progress in younger patients. Where you would not be likely to see an impact is if there isn't any progression in their disease to begin with, then it's not going to change anything. And then what you're looking for with cross-linking is halting progression. So you might get a little bit of flattening, but it's considered successful if the patient's just not getting worse. So I think sometimes what happens is a patient already has fairly advanced disease and they're coming in hoping, because they're desperate to see better, that the cross-linking is going to help them see better. And it really doesn't. It doesn't restore their vision. It's just trying to prevent it from getting worse. So that's an important part of counseling with patients and sort of setting their expectations about what the procedure can and cannot do.
Great, thank you.
Let's go to Rochelle.
Hi, thank you so much for all of this and for embedding those pictures of the videos of you doing the surgeries. Those were the highlight of my day. So I have a quick question. If you have any ideas on how many programs is typically the average for people to apply to? So you said some people just throw out there and try and do all 100, but is there an average that people do well with, like 15, 20? What tends to be the most appropriate?
I think that the key is to have a broad, and some of this is going to depend on how competitive your application is, but you want to pick a range of programs. So some that might be a little bit, much like when you applied for medical school or for college in the first place, some that are a little bit of a reach, some that feel like they would be more within your reach. And then I don't know that any ophthalmology program is a safety program, but, to the extent that it's a safety program, something that that you'd be comfortable. And, I think applying to, probably 40 is a reasonable place to apply. You're not going to interview at that many, but you're not going to get interviews at all of the programs to which you apply. And again, that's not knowing anyone individual's specific application.
Thank you.
Mm-hmm.
Babajide, do you want to ask your question?
Yes, thank you so much for having this talk, and I apologize for my camera not being on. I'm still driving, but I wanted to ask, what are your thoughts on like students taking an extra year between their third and fourth year to strengthen their application for ophthalmology?
Yeah, so that is a good question. And I would say that in part, that's very individual. Where I see that as being most helpful is if someone was really late to the game in deciding on ophthalmology. So in the past, I've had students that, fortunately discovered at the end of their third year that ophthalmology, fortunately or unfortunately, I think it's fortunate because what a shame if they missed the chance to see ophthalmology and find their true love. But, unfortunately, they didn't see it until the end of third year. And so by that time, to try to build what you need for an application into the subspecialty is really late in the game. And so then taking a year to start doing some research, start building connections with some faculty members is very helpful. The other area where I've seen people take a gap year is more so after the fact, in the sense that they applied and didn't match, and then they'll do another year to do research and to strengthen their application. So, sort of right off the bat, if you have sort of hit the points that I talked about already because you started the process early, I don't think it's always necessary. But again, some of these things are really hard to control because sometimes maybe at your local school, there isn't a lot of access to ophthalmology mentorship and research, et cetera. And so in that case, if your program and your school curriculum doesn't allow you to travel elsewhere without taking a gap year, that could play a role if you don't have sort of local resources to do some of the things I mentioned.
That makes sense. Thank you so much.
Mm-hmm.
All right, I'm looking down the line and I know we have about 5 minutes or so left. So I think we'll get to the folks who have their hands up now and then we'll kind of call it a night. Nat, do you want to go ahead and ask your question?
Could you talk a little bit about how to evaluate an ophthalmology residency? Because aside from rankings, what are some objective measures you can look to see if this is a good fit for you? Because I'm sure there's some hidden gems out there, but what can we look for to evaluate a residency? And an unrelated question, could you maybe talk about the opportunities for international work in ophthalmology, maybe if you have personal experiences with that or colleagues, and how feasible it is to integrate that into your career?
Yeah, so I think first, in terms of evaluating programs, I think some of this is, most programs have a lot of information on their websites. And so trying to understand what is the mission of the program and if that resonates with you and what your future goals are can be helpful. Looking at where many of the residents end up post graduation. So for example, if you think you're very keen on doing a subspecialty and you go to a program where most people are doing fellowships, then that's helpful. On the other hand, if you think you want to be a comprehensive ophthalmologist, then ending up in a program where a lot of people end up in comprehensive ophthalmology might be a better fit. Sometimes there's going to be other things that are in your life that affected, whether it's a significant other, the sort of family support, et cetera. Residency training is 4 years. And I think that, I had to couples match with my husband. It was very stressful, I'll be honest. We were very fortunate to match together. But it was really tough because we were apart from medical school, and I don't know that I could have handled another 4 years apart for training. And so these are just sort of very real considerations. And that totally directed where I was applying and where I was interviewing, because if there wasn't an ortho program that he could go to, then I wasn't going to go. So I would say that some of these things are going to trump everything else. But beyond that, I think that knowing sort of what the goals of the institute are, because your faculty mentors are going to help you accomplish what the next steps of your career are. And so if you have some ideas of what that is, if you really want to be on a path of getting a K grant, for example, and doing a lot of NIH funded research, then you want to go to an institution where people are doing that. And if you want to do a lot of international work in ophthalmology, then you want to try to identify some mentors there at an institution that are doing that. And I have not done a lot of international work outside of going in as a resident to the Aravind Institute for an elective. I've visited and sort of observed and been to meetings, but and we've collaborated, but there isn't the same sort of, I don't do a lot of missions work, although some faculty do that. I don't have like a heavy research collaboration where, I'm studying trachoma in Africa, for example. There's a lot of faculty, Sheila West and others at Wilmer Institute, for example, who have done that. So I think that some of this is all doable. It's a matter of how you're going to fit it into your life and your overarching goals. When you are doing a lot of heavy international research work, it does require traveling there a lot. And so I think it depends on sort of the balance of everything else in your life, how you could work that in.
Great. Let's go to Destine and then Matthew.
Hi, thanks so much for speaking with us. How is a secondary degree like an MBA viewed by programs?
I think that if you have a secondary degree that in some way you're able to say how you're going to work it into your career and it fits with your story, then that's a plus. If it's just there and there's no real sort of intentional planned use for it, then I would say it's neutral.
Thank you.
Hi, I have a question regarding research. I'm an M2 currently doing research with an attending cornea specialist and a resident who wants to do cornea. So pretty much everything that I've done is cornea focused. And I was wondering your thoughts on students who apply with primarily like research in just one area of ophthalmology versus students who have research in various subspecialties within the field.
So I don't think one area versus two matters. It matters, in my opinion, more so what your role was in the project, how well you understood it, whether you were able to take a project from start to finish. So, if you could do that with 10 projects, then yeah, that's amazing. But it's more important for you, in my opinion, to get one project done than to have 2 or 3 started in different areas and not have anything completed by the end of it.
Thank you.
All right. And for our final question of the night, Rochelle.
Hi, my name is Rochelle. I was wondering, there was a question in chat that really stood out to me, and I wanted to make sure we had the time to address it. So we know that research is an important factor for many ophthalmology residencies, but I did want to know in terms of quantity over quality, while there are like basic science research, for example, that can take years to even like get a manuscript out, not even get published because of the quality of the work and how much time that's taking versus some clinical projects that you could potentially spin out within 6 months or a year, depending on the patient population. So how would that be viewed by a committee?
Yeah, so I think that's a good question. I think that we do know that basic science projects are challenging to accomplish sometimes in a short period of time. It depends on the nature of the study. And, again, I think it really depends on what your contribution was. I think that in medical school, if you are doing your medical school curriculum along with the time and sort of just doing research on the side, we know that that's not a lot of time. On the flip side, you've gotten a PhD and spent 3 years in a lab. If you don't have a lot of basic science papers to show for all of that time, that reflects poorly on it. So I think that, if this actually comes back to the gap year. If you take a gap year and you don't have much to show for it, that also is not a positive finding, because I think, again, if someone has taken more time outside of their medical school curriculum time to do something, then the expectation is you'll have more to show for it. So you're raising the bar a little bit.
Thank you. That's reassuring to know that the time is taken into account. Thank you so much, Jan, for your time as well.
Sure, my pleasure.
All right. I think with that, we're going to bring the evening to an end. Once again, from everybody in the Zoom call, huge thank you to Dr. Srikumaran for joining us tonight, getting the season kicked off on a high note. Just a reminder for everybody, we are going to put this recording together. We'll email it out. It might take us a week or so just to get it all tuned up, but you can expect to see that coming out soon. It'll get posted on our website, of course, too. I dropped a short link to that in the chat. Once again, if you guys are interested in checking out any of the talks from previous years, you can definitely go ahead, check that out on the website. Once again, a huge thank you to everyone for coming out tonight. Please consider joining us again for our next event, which I'm happy to announce is going to be on November 8th at 5:30 Eastern Time with Dr. Lucy Young, the Associate Professor of Ophthalmology at Harvard Medical School and Senior Scientist at Massachusetts Eye and Ear Institute. Once again, thank you all for coming out tonight. We'll see you at the next one. Have a good night.
Good luck, everyone. Thank you.